This is Dr. Tom Dombrowski with Chapter 2 of Weber and Kelley. Subjective data is any sort of data that you get from another person, such as the patient. You get this data from the patient. It includes the patient's description of their sensations, symptoms that they're experiencing, perceptions, their desires, preferences, beliefs, ideas, values, and their personal information. And then going back to the previous slide, subjective information is the topic of this chapter. We'll be dealing with objective information in the next chapter. The phases of the interview are introductory, working, and summary and closing. We'll look at each of these phases in turn. And before you get to the introductory phase, you're going to want to do some pre-introductory work if you have the opportunity to do it. You don't always have that chance when things are busy, but if you have an advance warning that you're going to be getting a patient, you may want to do some pre-introductory work in, say, reviewing the medical record. And this may help you to better prepare for receiving that patient. In the introductory phase, you will be introducing yourself to the client and building trust. Those are the main point of the introductory phase is to build trust. So you'll be describing or letting the client know the purpose of the interview and what kinds of questions you're going to ask. You'll also be explaining why you need that information, and you be assuring them of their confidentiality. This doesn't necessarily take a long time, but it is very important because building trust is key to the rest of the whole interview. It's key to how fruitful the rest of the interview is going to be. In the working phase, you'll be doing such things as collecting biographical data and exploring the person's health concern, their reason for seeking care. We'll look at there's a mnemonic called cold spa that we'll be looking at in a later slide that deals with history of the present concern. You'll also be gathering the patient's family history and doing what we call a review of systems. That's what you've all done this if you've ever been to any healthcare provider, where after hearing about your reason for seeking care and your health history and all this, the provider probably asked something like, so have you had any dizziness, any headache, any issues like that, any ringing in the ears, any blurred vision, etc. So you did not come in for any of those things, and you didn't have any history of any of those things, but the provider is going to go down a list of various things that you might have, and then perhaps he or she gets to, and did you have any drainage from your ears? Oh, yes, I do. I do have that. And oh, okay, so then that gives them an opportunity to explore that and identify a problem that wasn't your main problem for coming in, but is a problem that you're currently having. Other portions of the working phase, we'll want to explore lifestyle and health practices. And there are various things that we explore under that heading. Developmental level. In other words, is their developmental level consistent with their actual age? For example, maybe let's look at a 16-year-old. A 16-year-old could be at a developmental level consistent with her age, but perhaps she's acting, perhaps her developmental level is actually a more childlike developmental level, and you'll see patients like that where it's a developmental level more appropriate to, say, a 12-year-old. Then also during the working phase, we'll be identifying problems and goals, and we'll be working with the patient to do that. Your approach during the working phase depends on the client and on how much time you have and the circumstances. It can be very free-flowing if you have time and everything's going smoothly, or it may have to be structured. So there are some clients that if you take a free-flowing approach, you would never get anywhere because they'll go off on all kinds of tangents. Other clients know what they're there for, and they know what they're about, and you can allow them to be free-flowing and you get the information you want. You probably have to include some structure but also some free-flowing elements. You probably need to do a mixture of the two approaches. Then the final phase is the summary and closing phase, and you kind of make a brief summary of the information from the working phase, and you develop some goals, identify some problems and set some goals. You discuss these with the client and you come to a mutually acceptable plan. And also you should offer an opportunity for any final concerns or questions, and make sure that you and the client are both on the same seeing things, that you're in agreement about the goals. Now, it's important to look at nonverbal communication because whatever our verbal communication might be, many times the nonverbal communication can either help our verbal communication or it can undermine it. So the nonverbal communication aspects we want to look at include your appearance, your demeanor, and also the patient's too. It's a two-way street. You're interpreting their appearance and their demeanor, and facial expression, general attitude, use of silence, and listening. So appearance should be professional. Wear comfortable, neat clothes, and you may think, well, it doesn't matter. I'm a very qualified, intelligent person. It doesn't matter how I dress, but it truly does. People tend to form their first impression on you based on what you look like. And if you look like a healthcare professional, that is going to carry you a long way, even if you're not that confident, or even if you're a little unsure of yourself. That professional look is going to carry you a long way. Make sure that your name tag and the credentials on it are visible. And of course, hair and fingernails should be neat. Hair must be kept out of the patient's face or out of their way. Many times we're bending over patients. and we don't want our hair to be drooping into there onto them. And wear minimal jewelry. It can be a safety hazard in nursing work. If you excessive jewelry can be a safety hazard. As far as your demeanor, you should focus on the client. Don't When you're with the client, try to avoid distractions. Sometimes that's difficult to do, particularly when you're first coming on, and perhaps you go in and greet your client, and then first thing you know, your spec phone, which is the phone that the hospital issues you, rings, and the charge nurse tells you, oh, I need you to do this, and you have to be sure to explain to the client, oh, well, I've been called away, but I'll be back at such and such time. So display poise, focus on the client, greet the patient calmly, using proper names. You will, I'm sure, hear nurses calling patients sweetie, honey, that kind of thing. Don't do that. Use proper names. If the patient is agreeable to it, you can certainly use their first name. Many, depending on their what generation they are, like older adults tend to prefer to be called Mr. Jones, Mrs. Smith, but they may even older adults may tell you, well, just call me James. Or they may so whatever the name the patient prefers is what we should call them. You should avoid being overwhelmingly friendly. Like, I don't know if you've ever been to a store or somewhere and the salesman came up and was just too utterly friendly, and it raised your guard, and you just didn't want to have, you wanted to get out of there as soon as possible. But it's quite possible to drive people away by being just a little overly friendly. So don't do that. And be cautious with touch. Touch is certainly a good thing most of the time, but there are situations and there are people where touch can be problematic. Your facial expression should be neutral and friendly. Again, you want to, appear comfortable and calm, but you don't want to appear just overly overjoyed or something. And also, there are times when you may have something, just maybe something really bad happened at home, and it's hard to hide that. And you may, in those circumstances, you may want to briefly explain something like, well, I know I really seem like I'm flustered today, but I had a very rough day, and it's not about you. And certainly that's something you might want to consider doing sometimes. It kind of takes the burden off of you of trying to appear to be all happy and everything's fine, and it also explains to the patient that it's not some problem that with them that has you down. And then you should demonstrate concern when appropriate. So if you're just all smiles and smiling, and the patient starts telling you about deep problems and you're still just smiling and maybe even giggling, why then the patient may feel like you're not taking their problems seriously. So you'd want to demonstrate concern and empathy for their situation. Oh, I went too far. Your attitude. Attitude should be non-judgmental, and that takes a lifetime worth of work, because all of us have things that we're frankly judgmental about. You may be, for you it may be drug abusers or child molesters, or I don't know what, but you're judgmental about certain things. And that you have to lay that aside when you come to the healthcare setting. Like maybe you think that unwed mothers are just immoral women and they're ruining our society, and so here you have a single mother. You have to lay aside your judgmental attitude for your shift anyway. When you go home, you can rant and rave all you want about these unwed mothers and how they're ruining our society. But for that 12 hours that you're at the hospital, you need to focus on being a non-judgmental nurse. Keep the focus on healthcare, because you're going to have a lot of people that you are going to say, well, she made herself sick. And there's probably some truth to that. She probably did do some things that made her sick and put her in this position. But being judgmental is not going to get you anywhere. So you want to keep the focus on her care and working with her, and what is possible to do in this situation. You want to, at all costs, you want to maintain the nurse-patient relationship. Once you lose that, it's very hard or impossible to get it back. So you want to preserve that nurse-patient relationship. And the best way to do that is accepting clients as they are, because however much we might wish they were different, wishing is not going to accomplish anything. And being judgmental is not going to accomplish anything either. So we have to focus on what is possible in the situation and trying to look for the best possible outcome for the patient. And using silence, you may have learned in Intro to Nursing certainly about therapeutic communication techniques, and using silence was one of them. For one thing, some people will, this invites the other person to talk, and you may draw them out, especially if you have somebody that's not been very forthcoming. Sometimes using silence will put the pressure on them to talk, and they will start to express themselves. It also provides an opportunity for both you and the patient to reflect, and sometimes I think your mother may well have told you something like better, here, wait before you speak. Don't be too hasty to speak. Wait and reflect a little bit before you speak. And also it demonstrates, to be silent with somebody for a while can be a powerful demonstration of caring too. And then part of really being a good interviewer, most of it is being a good listener, because unless you're attentive and alert to what the patient's actually telling you, even if you're asking the right questions, you'll probably miss a lot of the valuable information. So you want to maintain good eye contact and generally smile, although there are times when it's not appropriate to smile, like when they're telling you things that are really emotional or that are hurtful to them. Maintain your body position open. Don't be crossing your arms, crossing your legs. Maintain an open body position. And avoid preconceived ideas or biases. Many times, like sometimes it's really bad as far as some nurses will have biases against about certain disease conditions, like if the patient has liver failure. Oh God, another alcoholic that's wrecked his liver. Well, we know that certainly alcohol abuse can lead to liver damage, but there are other causes as well. And avoid use of electronic devices when you're interviewing a patient. Don't be texting or using the electronic devices. Unfortunately, sometimes we almost, like, for example, you may be using some sort of device to get the interview questions, so it may be unavoidable in some circumstances. And then, of course, you have that hospital issued phone that most of the hospitals are giving us, that they're calling all the time on that. So some of that may be unavoidable. Communication barriers. Well, there are some on the nonverbal side and some on the verbal side. So one of them is either excessive or insufficient eye contact, and that's going to be somewhat a cultural thing, or depending on the situation too. Like if you're using excessive eye contact, staring, that can be perceived as aggressive. But if your eye contact is insufficient, that can be perceived as being disinterested or evasive, or that can also be a problem. Distraction, obviously that's a communication barrier. If you're distracted, people, if they don't think you're paying attention, they're probably not going to invest much in the conversation. And distance, if you're not close enough, if you're too, just pop in the door, oh, how are you doing, Mr. Smith, and just pop out right away. Standing also, if you can sit down to talk, and people perceive, if you sit down with the client, people will perceive that you spent more time. Like there have been studies where nurses either stood or they sat down, and they spent exactly the same amount of time, but the patients perceived that the nurses that sat down spent more time with them than the nurses that stayed standing. Then some of the verbal ones, using biased or leading questions. So of course the most famous one is that old question, when did you stop beating your wife? That's a great example of a leading question. In a nursing context, that would, maybe you could say something like, well, of course you do check your blood sugar every day, don't you? And so the client is going to say, oh, well, I better say yes to that, even though I haven't checked my blood sugar in weeks, but I better say yes to that. Rushing through the interview, and many times, it's a fact, many times we're pressed for time and we've got lots of things going on. But rushing through the interview, you're probably not going to get very high quality information. And just flat reading the questions is probably not, most of the time that's not a good thing to do. You'd probably want to rephrase them and make them a little more personal, rather than just read them from the computer screen or from a script or paper that you have. But there are times when it's helpful to just read the questions, and those are things when you have a question you're not really comfortable asking, like maybe you think it's too intrusive, like maybe something like, are you a victim of violence in your home, or something like that, and you're afraid to ask, or you're really hesitant. You think, you should say, oh, you might want to be obviously reading it, so that way it kind of takes the pressure off of you, and the client knows that you're reading it from the assessment form or template that the hospital's provided you. So sometimes it can be your friend to read the questions, but usually it's a communication barrier. So some of the things, verbal communication, that the book recommends, they recommend, they have their pros and cons, shall we say. We have open-ended questions, closed-ended questions, laundry lists, rephrasing, using well-placed phrases, inferring, and providing information. So, open-ended questions. They are questions that cannot easily be answered in 1 or 2 words. So they're intended to elicit client feelings. And often they would begin with how or what or things like that. And they're very helpful to allow the patient to answer thoroughly and to express her or his feelings. And they're great for that. The problem with them is that sometimes they don't give the client enough direction, and so sometimes I've had students in the past that got the misinterpretation that they should only use open-ended questions. They should never use closed-ended questions. And if you really tried to live a day just using open-ended questions, you would probably, for example, if you just wanted to know the age of somebody, like, how old are you or something like that, well, tell me about your birth, or tell me about, if you were just doing it with open-ended questions, you could go round and round and round before you ever found out how old they were. So the idea that open-ended, you should only do open-ended questions, is not true, but they are very helpful in many circumstances. Closed-ended questions are used to obtain specific information, and they often begin with when or did, like, do you smoke? Yes or no? Well, you may want to know, and if they say no, did you ever smoke? And no. And then the only other thing to ask is, are you exposed to secondhand smoke? But tell me about your smoking, or tell me about, so you might, sometimes you want specific information, and that's all you want. You don't necessarily want to have a long conversation about some aspects. I mean, maybe some aspects of things you would want to allow the patient to thoroughly express herself or himself, but there are other aspects of the health interview where you just want specific information. A laundry list, it's like, for example, if you're asking about chest pain, you could say, well, would you describe it as stabbing, burning, crushing, or like, you can give them a list of several options, and they choose which option best describes their pain. And so it is helpful as far as if the patient's left to her own devices, she might say something like, well, this pain is rumbling, and you would be thinking, what on earth is rumbling pain, or something like that. She might use some descriptor that is not meaningful to you. Where if we have chest pain that's, say, crushing, or why, then that tends to suggest that it may be a heart, ischemia to the heart, as opposed to stabbing, which tends to suggest that that might be a problem with the pleura, with the lungs. But not always, but it tends to suggest that. So we're using the laundry list while we kind of channel that patient into certain words that are meaningful to us. Laundry lists can be confusing if you ask too many things at once. Like sometimes if you're doing a review of the system and, oh, have you had any nausea, vomiting, diarrhea, heartburn, or, and so you go on and the patient says no, and maybe they did have one of those things, but you kind of asked so many of them that they forgot it in the shuffle. Rephrasing is a good communication technique. It does several things. For one thing, you can use it to help clarify or to validate what you think the client means. Or sometimes it allows them to give you some more information about a problem. And it also communicates to them that you have understood the problem, or sometimes it communicates that you have misunderstood the problem, but in any case it gives them the opportunity to help clear things up. Using well-placed phrases. So by this we mean just kind of little phrases that encourage them to continue. And it can, if they're not well placed, why then it can sound like you're just giving routine responses, so you have to be a little careful about that. But for example, if a client is talking and going on and you aren't saying anything, after a while they're not sure whether you're even listening or not. So you may want to use a well-placed phrase to say, well, yeah, yes, I am still listening. So you could say something like, oh, please go on, or, oh, well, that must have been upsetting, or things like that. So you would want to use those at strategic points in the conversation. Providing information. This is another one of those tricky ones. Because one of the communication tips we learn early on in nursing is don't give advice. And by that I mean sometimes the patient will say, well, if you were in my place, what would you do? And that is a minefield, because you don't really understand their situation. I mean, you think you do, but you don't. For one thing, it takes the responsibility that should be theirs, and you're taking that on. So, it's like if it's making you responsible for something that is their responsibility. So you don't want to be giving that kind of advice. But we do have to provide information and teaching, and a lot of times what the teaching is on recommendations even, and a lot of times that sounds an awful lot like advice. But advice is like, well, if I were you, I would, or, I think you should, or things like that. And that is inappropriate for the healthcare provider to be doing. But certainly we can make recommendations, like we can say, well, these are some of the risk factors for cancer, and by reducing these risk factors you can reduce your risk of cancer. Or given your history, given your family history, you're at higher risk for stroke, heart attack, and so some of the things that can be done to help prevent that are. And then also when patients will sometimes ask you things that you just don't know the answer, and you'll be tempted to say, oh, well, you should ask your doctor, or you should ask your pharmacist, but really commit yourself to finding out the answer and getting back to them rather than referring them to somebody else. That's usually the best course, is to commit to finding out. And you may not be able to find out all of it, but you can at least get the process started. And you may not be the end. I mean, in many cases, they do need to talk to a doctor or some other provider too, but you can get that ball rolling. Now, there are some special communication considerations for example, the geriatric client or older adult. Also, cultural variations. Sometimes we'll get clients that don't speak English, or clients that maybe do speak English but come from very different cultures. Uh, and then there can be emotional variations where there's the communication, like we think that our patients are all going to be nice people that speak in polite tones and all that, but that's certainly not always the case. So, geriatric client. First, be aware of normal age variation in body systems, because sometimes if you're not, you may take something to be a pathological thing when it's actually a normal change with aging. So the first thing is to be aware of those normal age variations. And with a geriatric client, it's important, before you do anything else, make sure that they're hearing you. And a lot of times there's a degree of hearing loss. I mean, even your faculty, half of us have a little bit of hearing loss. And if there is some hearing loss, you want to speak slowly, face the client, and speak toward the side with better hearing. With older adults, it's especially important to show respect, and they are going to probably have more health problems than your younger person. Like, not always, because you will have some that like sometimes the avoiding prejudging the client. Like sometimes your charge nurse will come to you and say, oh well, you've got a 30-year-old coming with abdominal pain, and you think, oh great, a 30-year-old, only one or two problems, I'll get the assessment done in 30 minutes and move on. And then that person comes up and she has a list of healthcare problems longer than anybody you've taken care of in a month. And then, but on average, your older adult is going to have more health concerns and your younger adult will have fewer. Culture variations. Now, it's not all about language. There can be variations in communication style too, where for example, it may be considered in some cultures it's not proper to talk too much about yourself, and so the client may not be comfortable talking about herself like we would in our culture. We talk about ourselves incessantly. We even go on TV, national TV, and talk about ourselves and our problems and all that. That may not be acceptable with some cultures. And you may need what we call a culture broker. A culture broker can be anybody, but they have to meet two requirements. They have to understand the language and culture of the client, and they also have to understand the language and culture of the healthcare providers. So for one example would be, say, if you have an immigrant from El Salvador, and she just arrived a week ago and now she's in the hospital. Your culture broker might be somebody in the community that came from El Salvador 20 years ago and has now learned all about the U.S. system, and they speak English, and they still know the culture that she's coming from, but they also know our culture. It can be another nurse, maybe. Say maybe you don't. Maybe you have a nurse that worked in El Salvador for a while or something. Or it could be a respiratory therapist, or it could be they may or may not know about healthcare, but they should know the culture of the healthcare providers and the culture of the client. And so they're not only going to and it's not primarily the language. Like we could get anybody that could speak Spanish, but that person may or may not know anything about the culture of the client, and that we're primarily looking for somebody that can interpret to us what the cultural meaning of the client's behavior and communication is. You might need a culture broker for people that speak English. I recall one situation many years ago when I was working psychiatry. We had a woman that she had what we thought was schizophrenia. She was talking about that spirits and things, and it turned out that she was actually a voodoo person who was known as such in her community, and somebody had broken into her house and raped her, and she was could not believe that something like that could happen to a person like her. And when we learned all that, that changed the physician changed the diagnosis, that it was not a schizophrenic problem, it was a reactive psychosis problem, which was a different thing. So the culture broker in this case were some family members that were able to explain the situation and the culture that she was from. Then the client may be other culture variations. People from some cultures may be reluctant to express emotions, or they may be reluctant to talk about certain things, like maybe sex or drugs or whatever. And also, in some cultures, somebody else may be the decision maker, and that will present us with various conflicts. Because for example, maybe we have a woman that as far as we're concerned, she's the one that makes the decision, she's the one that gives the consent. That's the legal situation in the United States and all this stuff. But when you ask her, well, okay, do you want to proceed with this surgery or not? Oh, well, I have to ask my somebody else, maybe her husband. And then sometimes we will be kind of gritting our teeth, like, how can she be living like that, having to ask her husband? And so it may be difficult, things that maybe or we may even consider that maybe there's some abuse going on there, and certainly there could be. But the culture enters into the whole situation as well and complicates it. And then also there may be differences in the meaning of nonverbal communication from one culture to another, to the extent that, for example, in some cultures, nodding your head up and down, which we take to mean yes, can mean no in some cultures. So we can misunderstand such basic things as that sometimes. Certainly there can be language barriers, but there's also variations in the way diseases are perceived, or the way hospitalization is perceived. And there is a thing called culture-specific syndromes. One example in Hispanic America, Latin America, there's something called susto, which is a situation that shocks you, or an kind of drains your energy. And then there are various other culture-specific syndromes that occur in other cultures. And usually they are treated by, they wouldn't be treated uh, by medical people most of the time. They'd probably be treated by uh, either by the family or by folk healers or something like that. As the people involved would probably say, well, the doctor can treat my diabetes, but he doesn't know anything about Susto or something like that. There can also be variations in time orientation where some cultures value the future more highly than others. Other cultures are more focused on the present or near present. And other cultures are even focused mainly on the past. So there can be differences in what the importance of. So if you have somebody that is mainly focused on past glories and on honoring the ancestors and the past, they're probably not going to be too anxious to do preventive type things. I mean, they're not really focused on the future. So they might do some preventive things if they're easy, but if you have to do a lot of work and expense and trouble to prevent something, they're maybe not that interested in it. And then there can also be variations in locus of control, where, and by that we mean who do you think or what do you think controls your destiny or your fate. Where, you know, some in U.S. culture we tend to think we have pretty much have control over our futures. Not everybody in our culture thinks that. There certainly you'll find people that feel powerless, but on average in the US we tend to think, you know, we control our own destinies. But then there are other cultures where people tend to feel that powerful others control their destiny, or that they don't have much control over their destiny at all. So, using interpreters, patients have a right to an interpreter, and the hospital has to provide it, and we can't charge them extra for interpreters. We usually, what we do, we have language lines where we have a two-way phone where you can get on the phone and put the patient on the phone, and you call, and the interpreter is somewhere wherever they're at, and they interpret what you say. But you might have an interpreter in person who is talking to you and to the client. And if you do, why then look at the client, not at the interpreter. Don't use friends or family members for several reasons. For one thing, they may not give they may, you know, give an interpretation that's not that's not an exact interpretation of what the patient's saying. They may tell the patient things to their own convenience, and even if they don't, why, it can alter the family dynamics, especially when you've got children that are interpreting for their parents. That can alter the family dynamics in a bad way sometimes. You should watch the client's face, and you should validate that they understand, meaning that ask questions and get feedback to make sure that they're understanding what you're saying, and avoid using medical jargon or technical terms. There are several emotional situations where the communication is varied too. You could have clients who are anxious, angry, depressed, manipulative, seductive, and then there's the problem of discussing sensitive issues with clients. The anxious client, you want to be, keep your information organized and keep it simple. Because this client, if you introduce any unnecessary complexity, they're going to be, that will increase their anxiety. So you want to keep it focused and on point, because if you sometimes you'll go in and you'll be saying something and you'll be just mention something else, and that isn't really pertaining to the situation, and oh, is that bad, was that dangerous, and anything, it's sort of like anything you say, they will take it in the worst way. So you want to keep it simple and organized. Want to explain what your role is in their health care, and what your purpose is in the conversation. And you want to be simple and concise with your questions, and above all, don't become anxious yourself, because it is kind of contagious. So you probably have to maybe do some deep breathing and take care of yourself and do some preparation for yourself too. And then don't hurry through the interview. The angry client, you want to be calm and avoid getting angry yourself. You want to be calm and reassuring, and be in control of yourself, and in control. Allow the client to ventilate, but make sure that you have a clear pathway to get out. Don't get too close. This is one time you do want to use distance, and you don't want to get between, you want to have the door, be near the door so that you can get out if you need to. Get help when needed. So don't argue or touch the client, and like I say, be sure that you can get your help when you need it. The depressed client. This one, you don't want to go in just with this really overly smiley, overly friendly approach with the depressed client. That's not helpful at all. So the recommendation is to keep a neutral emotional expression. You don't want to get sucked into the depression or feed into that, but you also don't want to be, oh, life is beautiful and all this Mrs. Sunshine either. And do express interest. These patients are kind of hard because if they're profoundly depressed, why, they'll take everything and turn it into ashes, and it can be just like the other patients that kind of draw you in, and where the anxious patient makes you anxious, the angry patient makes you angry, the depressed patient can easily make you depressed too. The manipulative patient, this one's another difficult one to deal with. You want to set limits, definitely set limits, and hold to them, and make sure that they're limits that the team will back you up. And you want to work as a team, because this patient will tend to play one nurse off on another. They'll play the nurse off on the doctor, the respiratory therapist off on the nurses. They'll play anyone off on anybody else that they can. So you want to definitely work as a team with this one. They want structure, so yeah, you provide them with a structure and predictability. That's important to them. And if you have to distinguish when they're manipulating and when they're making a reasonable request, because sometimes you can be so into setting limits that maybe they like maybe they are making a reasonable request and you almost miss it, and so like it's sort of the saying that even a broken clock is right twice a day. Finally, the seductive patient. And this one you need firm limits, and you need to make sure your supervisor knows about the situation, and you may need to have somebody else go in with you when you go in. You want to let them know that the seductive behavior is inappropriate, and you want to encourage more appropriate ways of coping and relating with people. And avoid responding to subtle seductions, like they may, like it's sort of like, oh, you look nice today. Oh, well, thank you. Well, like you don't want to be sucked into that at all. So the complete health history, it starts with biographical data, then reason for seeking care, history of the present concern, personal health history, then family health history, review of systems, lifestyle and health practices, and the developmental level of the client. So biographical data, there's a number of things, and this is not everything by any means. There's other things we could also include, but basically like their name, their demographics, name, address, their gender, which usually that's going to be male or female, although now we do have people that don't identify with a particular gender, and then we have transgendered people, so that may be a concern. Who provided the information? You think, well, the patient did, but not always. Sometimes think of a baby. In the case of a baby, who provided the information? Or the case of an older adult who has dementia and cannot speak or meaningfully. This kind of information, the name, address, gender, if you're going to do like a class assignment, that's information that should be omitted, because you don't want, if you're doing like an assignment and you have to present a case in post-conference or something, you don't want to be saying, oh, Mr. Jones, and he lives in Colleyville at 323 North 3rd Street. So you would either use initials maybe, or yeah, and sometimes you would even maybe disguise and maybe change some of the facts of the case in order to make sure it couldn't be traced. The client is considered your primary source. Remember, we've talked about primary sources where, like a book, say, where if you have like Gene Watson's theory of caring, and you have a book by Gene Watson, that's a primary source. But if you have a nursing theory book that is by somebody else that talks about Gene Watson's theory, that's a secondary source. So the same way, the client is the primary source and everybody else is a secondary source, such as, I don't know, wife, children, etc. Other biographical data, which we wouldn't necessarily write anywhere, but we'd want to be aware of sometimes. Well, and some of it we would write different places. Their ethnicity. And that would be probably how they define themselves. There's all kinds of variations in that, where, you know, then that would be a self-definition. Their religion, what languages they speak. So, and one of the languages will be primary, and then the other would be a secondary language. So, usually the one that they were born or grew up speaking is the primary language, but sometimes, like if you uh, immigrate at an early age, like say you grow up speaking a language till you're say 9 or 10, and then you spend the next 60 or 70 years speaking another language, why then that second language could end up being your primary language. Because if you don't use it, you don't entirely lose it, but uh, you do. And then the interesting thing of that, though, is that the languages, secondary languages that you learn, reside in different parts of your brain than the primary language. And so sometimes people have a stroke and they will lose one of their languages but still be able to speak somewhat in the other one. Other biographical data is education, occupation, and their living situation. And by that I mean, do they live at home by themselves or with others? Do they live in a nursing home, an assisted living situation, a jail, a homeless shelter? All kinds of possibilities for where their living situation might be. And then reason for seeking care. And so that's often called chief complaint. Weber and Kelley say that it's more holistic to call it reason for seeking care. And they say the two big questions for that is, what is your major health problem? And how do you feel about having to seek care? So, and then there are, of course, other follow-up questions to that. History of present concern, and this is where you're going to learn this cold spa very well, so you might as well start with it now. These are all the things whenever a person has a symptom or a complaint, or you're going to do cold spa on it. You're going to find out the character, onset, location, duration, severity, pattern, and associated factors. So you'll be learning that really well. Some of the things to ask about in their personal health history are, did they have any childhood illnesses? And did they have any adult illnesses? Also surgeries, accidents, prolonged pain, or maybe chronic pain. Do they have allergies, and what kind of reaction? What are they allergic to, and what kind of reaction do they have to it? And what medications do they take? For family health history, in lab you'll be doing a genogram, and that kind of gives you an idea of how to do a family health history. You want to go back at least 3 generations, meaning to grandparents, and also include your own children, and include as many, in the health history you're going to include as many relatives as the client can recall. And so you'll have annotations like 39L/W, meaning 39-year-old living and well, or 44 diabetes, meaning 44 years old, alive, and has diabetes. Or then they could be deceased at 69, and then you would give a cause of death, or sometimes it's a unknown cause of death. The review of systems we've already talked about a little bit. It's specific questions about each body system. So you came in for headaches, intractable headaches, but I'm going to ask you about everything from head to toe. So I'll be asking you about nausea, vomiting, diarrhea, etc. And you didn't come in for any of those things, but I'll ask you about them because you might have some of those that you forgot to mention. And it's important to only include what the client tells you in the review of systems, because maybe you notice that they have a cough and that is going somewhere else. That's not, if you notice it, why and it wasn't something you asked about, why then you shouldn't mention it in the review of systems. That would go somewhere else. Note both what the client admits to and what she denies. So you could summarize it by saying admits to nausea and vomiting, denies diarrhea, chest pain, and so on. And so by saying denies these things, why then somebody reading the record would know that you asked about it. And be sure to put the questions in terms that the client understands. Because many times we think that they understand all our medical language and they actually don't. And then sometimes they're too embarrassed to say anything, so they just say no. So lifestyle and health practices, there's a number of things here, including strengths and weaknesses, description of a typical day, nutrition and weight management, activity level and exercise, sleep and rest, and then substance use. So that's everything for the chapter 2, the subjective assessment.